Okay, excellent.
Okay,
Krystyna?
perfect. All right, thank you everybody for coming. Today we're going to go over diabetes and cardiovascular disease, kind of what's the update for 2023. And then, oh, where? Let's go. Okay, so we're going to review the diabetic guidelines and what's updated in the past couple of years. There's two new medications that are now mentioned in some of the guidelines, so finerenone and trizapeptide. I'll go over kind of the evidence for those. And then just some type 2 pharmacotherapy tips in terms of when we start these medications, kind of what you need to look out for, and so forth. So for our A1C targets, nothing has changed since the update in 2018. New diagnosis is still considered 6.5 and above. Most of our patients who have cardiovascular disease were aiming for 7 or below. The patients that we would be considering higher would be those who are at risk for hypoglycemia, those who are frail or elderly. So the ones we'd be more concerned about having hypoglycemic episodes that would cause them harm, obviously, with that. So the Canadian diabetes guidelines, they were last updated, last published in 2018. The last update for type 2 therapy was in 2020. There's been multiple new trials that are not obviously reflected in these guidelines or even in the 2020 update. So a lot of the ones with our SGLT2s in terms of our kidney outcomes, and then with the heart failure, both preserved and reduced ejection fractions. So those ones are obviously not reflected in the guidelines. But for the ones that were published in 2020, they still recommend metformin as first line if our A1C is above our 6.5 mark, and then to recheck that after 3 to 6 months, and then you would escalate therapy. Obviously, if their A1C is significantly high, usually around 11 to 12, you might consider starting insulin with the metformin at that point. And then there still actually is that small recommendation that they recommend just lifestyle changes for certain patients if they're above target. So that might be our more frailer or elderly patients that you might consider that first line before you would start treatment at that point. If they're not at target, or if you need to add or advance therapy, they've broken down the guidelines kind of into two sides. So one is for our risk reduction. So our coronary vascular disease, CKD, or heart failure is on the left-hand side. So for atherosclerotic disease, they still recommend GLP-1 or SGLT2 first, and those are obviously the ones with evidence for that. CKD, they would recommend SGLT2, and then heart failure, as we all know, SGLT2s for that. If they are a diabetic patient who have risk factors, so not necessarily have developed coronary vascular disease, so someone with hypertension, dyslipidemia, that type of thing, then they would recommend a GLP-1 or an SGLT2 with that. On the right-hand side, you kind of see the bottom here in the red, where they have the sulfonylureas, insulin, just because they have hypoglycemia. The thiazides, those ones we don't really use too much anymore at all. But then again, kind of the GLP-1s, SGLT2s, and you'll see that's a common theme pretty much through all of the guidelines. This chart here, I threw this in here, it's from our Canadian diabetic guidelines. They break down all the trials in terms of the outcomes for all the trials. So the GLP-1s and the SGLT2s obviously have MACE evidence. There's CV mortality, all-cause mortality. The ones that have the fatal and non-fatal stroke evidence are our GLP-1s, so Ozempic and those ones. So if you have somebody who's just had a stroke, that would be the drug class to go to first. And then obviously hospitalization with heart failure and progression of CKD, that's our SGLT2s there. So in 2022, the Canadian Cardiovascular Society updated or released guidelines for cardiorenal risk reduction, and the focus on the GLP-1 receptor agonists and the SGLT2 inhibitors. I've just highlighted kind of the recommendations. So for heart failure, they recommend SGLT2s. It kind of doesn't matter where the EF is. They should be on an SGLT2. CKD, again, SGLT2s. And then if they have type 2 diabetes with either with established coronary vascular disease or multiple risk factors, they should be on a GLP-1 or an SGLT2 in that case. You might consider an SGLT2 if they are at risk for having hospitalization for heart failure or progression of CKD. And then, as I mentioned before, a GLP-1 if you're trying to reduce the risk of stroke for those patients. The American Diabetes Guidelines, they published an update in late 2022. So they had their standards of care for 2023. Kind of the same thing as you've seen with the, the Canadian guidelines. They broke it down into cardiovascular disease risk reduction, so our GLP-1 or SGLT2, heart failure, SGLT2, and then CKD, the SGLT2s as well. So it's kind of the same thing that you see from the Canadian guidelines that were published a bit earlier. It's definitely still the same trend going forward. On the right-hand side, they actually added a component for weight management goals. And in terms of lifestyle, but then our GLP-1s, kind of which ones have the highest weight loss with it. So semaglutide, which is Ozempic, and then trizepatide, which is Mounjaro, which is a new one on the market. Those ones have the best weight loss evidence out there. And then they also show in this side here for efficacy of glucose lowering. The GLP-1s are probably the best ones out there for quick glucose lowering. And then going down from there is kind of our metformin, SGLT2, sulfonylureas, and down that way. The one thing that I do like that these guidelines included is that they broke down each drug group and then actually listed each medication kind of based on where it is based on cardiovascular effects, heart failure, and then progression of kidney disease. So they still have metformin listed as the first one. In terms of mostly, I think it's still because it's does a good job in lowering our A1C, has a neutral benefit on weight loss. Most patients do still feel they have a little bit of weight loss. Neutral in terms of our heart failure and CKD, but does have some potential benefit for our cardiovascular disease. SGLT2s and GLP-1s are listed below. The ones that have the benefits are included kind of in the categories. There's some medications, obviously, that we don't have marketed in Canada that are on this. But it does provide a good overview in terms of what the ones that would be beneficial, kind of what concerns you might have, and then possible side effects and how to manage that for your patients. So the European guidelines are the newest ones that have been published. These were published, I think, in August of this year. So this is a very comprehensive guideline that goes over the management of cardiovascular disease in patients with diabetes. They cover everything from dual antiplatelets, hypertension, weight loss, and then obviously diabetic control that way. So this one, this is kind of just the overview of what they've included in their guidelines. Same thing, if they have established cardiovascular disease, they want you to be on a GLP-1 or an SGLT2. If you have heart failure, SGLT2s, and then chronic kidney disease, SGLT2s, and this is where they've added finerenone into their guidelines for here. The one difference is, so they'll still, if you have cardiovascular disease and type 2 diabetes, they're recommending GLP-1 or an SGLT2 right off the start. Metformin is now down kind of second line in terms of glucose control. So they're not recommending metformin first line anymore in their guidelines, which I thought was interesting. In terms of evidence, obviously it makes the most sense in terms of patient cost. So the medication obviously is much cheaper, metformin is, and then drug coverage might be an issue for some plans going forward because a lot of them want them to be on metformin before they would start, say, a GLP-1 in that case. And then for our heart failure, again, SGLT2 is first line, and they say if they have type 2 diabetes and heart failure, they should be on an SGLT2. And again, they recommended it above any of the other groups of medications. Metformin, again, kind of second line in that case. Other glucose lowering agents that we should be avoiding. So pioglitazone and saxagliptin, those are two that if anyone's at risk of developing heart failure or has heart failure, they should not be on these medications. So if you do find a patient that is on these, ideally we just get rid of them and replace them with something else. That's the best option. We should just not be using these in patients with cardiovascular disease, in my opinion. And then CKD and type 2 diabetes. And this one goes over more kind of the cardiorenal protection. So statins and then maximizing our ACE and ARB inhibitors. And then our SGLT2s, and then again, this is where finerenone mentioned. So finerenone is it's not necessarily a newer medication, but it's only come to the market in the past couple of years. It's a selective non-steroidal mineralocorticoid receptor agonist. The trial that's come up with the cardiovascular outcomes is the Figaro DKD trial. So they were looking at finerenone 10 to 20 milligrams daily versus placebo. They had a run-in period where the patients had to be maximized on an ACE inhibitor or an ARB first. So that's why there was 99% of patients on these medications. So they looked at cardiovascular events in patients with chronic kidney disease and type 2 diabetes. So they were looking at two kind of different groups, those with type 2 diabetes and CKD stages 1 to 2. So that's our eGFR of 60 to 90 with significant albuminuria, and then type 2 diabetes with CKD stages 2 to 4 with moderate elevated albuminuria. So around 8% were on an SGLT2, and then 8% were on a GLP-1 in the trial. Their A1C was 7.7, so they were considered kind of uncontrolled for these patients. Majority had a CKD stages of 1 to 2, which I feel is probably majority of where we see a lot of our patients. And then 45% had a history of coronary vascular disease. They did exclude patients with HFrEF, mainly because these patients should already be on an mRNA, so they should already be on spironolactone at that point. And obviously, we don't want to be duplicating therapy with that. The primary composite outcome, so it was a time to event, and it was cardiovascular disease. So it was non-fatal MI, all-cause mortality, hospitalization for heart failure, and then non-fatal or fatal stroke was their primary composite endpoint. Pretty much all of the data was driven, or the outcome was driven by the lower incidence of hospitalization for heart failure. Now that finerenone is an mRNA, kind of makes sense that that would be the main thing, as we know from evidence from spironolactone that way. Cost is about $120 a month right now. So it's much more expensive, say, than spironolactone. Spironolactone, we don't have evidence in CKD. So that's kind of where finerenone and the company is obviously thinking that this is going to fit. CADITH is the Canadian group that kind of helps the drug formularies make recommendations for coverage. So what they're currently recommending is that the patients need to be on a max tolerated ACE inhibitor or an ARB. They can't be taking another mRNA, obviously. No SGLT2 inhibitor, which is interesting, and then no heart failure or no active heart failure. No symptoms, obviously. So they can't have an NYHA class of 2 to 4. So I feel like that's going to rule out a lot of patients. And then so it's kind of unclear where it's going to fit in terms of therapy right now, because I feel like we're still going to use an SGLT2 in these patients over finerenone. So coverage is going to be an issue for a lot of patients, I think. Ongoing trials are looking at the combination of use of SGLT2 inhibitors and then recent heart failure hospitalization. So that's the confirmation HF trial. So that'll be interesting to see kind of what's going to come out of that. And maybe that'll give us a better idea of where this medication might fit in terms of therapy. So the other one that's out there now is trizepatide. So it's Mounjaro. It's a new group of medications. So I think there's another one coming to market too. This one was just released into market, I think sometime in the summer. So it's a glucose-dependent insulinotropic polypeptide. So that's the GIP receptor, and then the glucagon-like polypeptide one. So that's the GLP-1. So that's like Ozempic and those. These medications will actually help to lower your the blood glucose more. So there'll be more increased insulin sensitivity and increase glucagon and secretion. So it does help kind of in terms of better glycemic control for these patients. And then there's the added benefit of it has the increased weight loss with that as well. So the SURPASS-2 trial, there's multiple SURPASS trials. I think there's 6 in total. They were very broken down into the exact things that they were looking for. But the SURPASS-2 one is the one that showed kind of the evidence for glycemic control for these patients. So it compared the trizepatide to semaglutide, which is Ozempic, once weekly in patients with type 2 diabetes. So it was on 2021. So it was a non-inferiority multi-country trial. They compared 3 doses of trizepatide to semaglutide, the 1 milligram. So that's kind of our max Ozempic dose that we'll use for type 2 diabetes. And then they did the 3 different trizepeptide arms. The primary endpoint was a change in HbA1c from baseline at 40 weeks. All of these patients were considered uncontrolled, so they all had an A1C of 8 and greater. And they all had to be on metformin of at least 1,500 milligrams a day, and then have an EGFR of greater than 45. So for glycemic control, in terms of the results, they all 3 doses of trizepeptide were considered non-inferior, and they considered them superior to semaglutide. So as you can see in the chart, they all showed lower reduction in HbA1c over the 40-week period. The one thing that was interesting is that it seemed to all plateau at about 20 weeks. So once the patients were on these drugs for about 20 weeks, it kind of it plateaued to that effect. So they got the glycemic control pretty quickly, but then at least the effect sustained, but it didn't improve after that point. And then the secondary endpoint was weight loss. So they were looking at the reduction in weight over the 40-week period. So semaglutide still had a decent outcome over the 40 weeks, so still had about 5.7 kilogram loss. But all 3 doses of the trizepeptide all had shown more weight loss, with the highest being with the 15 milligram, which is the highest dose. And then the other side of that is that all doses of trizepeptide had higher GI side effects with them, with the highest being seen in the highest dose of the trizepeptide. So not really a kind of a surprise there. The interesting part was that they continued to lose weight over the 40-week period. It didn't kind of plateau at the 20 weeks as we saw with the HbA1c reduction. So in terms of a weight loss medication, it's definitely seems to be very good. So I think it's going to be highly marketed that way for sure when it comes. So there's a few ongoing trials looking at some other evidence. So the FLOW trial is semaglutide, so Ozempic, on kidney outcomes with type 2 diabetes on the background, again, of that max tolerated ACE inhibitor or ARB. And that's expected to complete at the end of 2024. And then the SURPASS cardiovascular outcome trial is evaluating efficacy and safety of trizepeptide to dulaglutide, so that's Trulicity, in type 2 diabetes with established cardiovascular disease. So I think once we get the evidence from that trial, then we'll see trizepeptide included kind of in our diabetic guidelines more, especially once we get a Canadian update. It'll definitely be on there. So just some general tips for kind of our main drugs. So the SGLT2s, a transient increase in creatinine can occur and last up to 30 days when we start these medications. So just something to be aware of when we do start them. Common side effects: hypotension, increased urination, increased diuresis. Fungal infections are definitely something that we need to counsel patients on. They need to ensure that they're doing proper hygiene. It's recommended we just manage each occurrence with antifungal treatment. It's not an indication to stop therapy, obviously, unless it becomes an issue for the patient and they're not willing to take the medication anymore. Dapagliflozin is now generic, so there's no prior authorization required for our provincial plan or Blue Cross, which is wonderful. Costs about $30 a month, so it's definitely now more accessible to all of our patients, regardless of drug coverage. Make sure we're not using these medications in type 1 diabetes because of the increased risk of DKA. And then if the patient's going for procedure or surgery, make sure we're holding these medications 48 hours prior, and then resume them once the patient's taking in oral intake. For the GLP-1s, weight loss is definitely a large benefit for a lot of patients. So a lot of times if you have a patient where you're kind of deciding between an SGLT2 and a GLP-1, if they're significantly obese, then a GLP-1 might be the better choice for that. Can cause significant nausea, the feeling full. Usually the symptoms are temporarily. They usually go away after about 4 to 6 weeks is what is said. Reduce meal size, decrease intake of high fat and spicy foods is one of the recommendations to kind of help patients with that. Dose titration over usually at least 2 months. You can go slower if there's ongoing GI side effects. So for Ozempic, we would start at 0.25 milligrams every week, And then we usually increase it every 4 weeks and to get to the 1 milligram dose. But obviously we can slow that down if we need to. Patients need to be able and willing to inject themselves. So that sometimes is a barrier. So it's just something to have a conversation with your patient. Weekly versus daily injections, Ozempic and Trulicity are weekly, Victoza's daily. So I feel like that one's kind of fallen out of favor just because of the daily injection part. We have currently the 3 that are easily accessible, obviously unless there's drug shortages, because that will happen at some point. But costs are about $200 a month with no insurance. So it's a significant cost out of pocket to patients because there's still some reluctance in covering these on certain drug plans. Ozempic is covered under our provincial drug plan with a special authorization, but they need to be on metformin prior or have tried metformin prior and failed. So that's one thing to consider with that. And then make sure we're not using the DPP-4 inhibitors, so sitagliptin with the GLP-1s, because they have a similar mechanism of action. You're not going to get any additional benefit with those. And then the other part, EGFR. So this is a common issue that definitely happens, especially to our patients in hospital. So if the EGFR is less than 30, don't use metformin. If their EGFR is kind of between 30 and 60, it's recommended to reduce the dose of metformin to keep it less than 1,000 milligrams a day. Use caution with sulfonylureas. So it's not an outright contraindication, but just if we are introducing these medications with a patient who has an EGFR less than 30, just kind of go slow, start low, go slow. Sitagliptin does require a dose reduction if the EGFR is 50 or less. Linagliptin is another option that we can use at actually any EGFR. So if the patient's developing kidney disease and we know it's probably going to progress and get worse, and they are on sitagliptin, we could make the switch to linagliptin, and then we don't have to worry about dose adjusting. SGLT2s can be initiated at any point prior to starting dialysis. The product monographs state don't initiate an EGFR less than 20. We'll definitely push that down to 15 when we need to, but it is something to consider. So, and continue the medication until dialysis is started. It's contraindicated currently for use in dialysis. I feel like those trials are probably going to come out, and then we'll probably be using them more even in dialysis, but we'll see. GLP-1s can be used with any EGFR, so we don't need to worry about their kidney function. Limited evidence for severe renal impairment or dialysis, but we definitely do use them in those patients. So kind of in summary, if a type 2 diabetic patient has coronary vascular disease or is at high risk, they need to be on either an SGLT2 or a GLP-1 or a combination of the two. If they have heart failure or CKD, start an SGLT2 inhibitor regardless of their diabetic status, and then obviously not in a type 1 patient. And now that dapagliflozin is generic, that's definitely much easier to do for these patients. So to initiate these treatments in type 2 diabetes, if an HbA1c is at target, if they're on a sulfonylurea or a DPP-4 inhibitor, stop those medications and replace with either an SGLT2 or a GLP-1. If the HbA1c is above 8%, then just simply add the SGLT2 or a GLP-1 to ongoing therapy. If they're on insulin, kind of regardless of where their A1C is, you may need to reduce the dose of the long-acting insulin that they're on, so by 10 to 15% when adding an SGLT2 or a GLP-1. And then don't forget to maximize the statins or the ACE inhibitors and the ARBs for these patients, because that's, again, part of kind of that cardiorenal protection with that. And that's all I have to say. So thank you very much.
Krystyna, thank you so much for excellent review and updates. Are there any questions from the audience?
I do, Krystyna. Can I ask a question?
Yep, go right ahead.
Great talk, Krystyna. It's more of a philosophical question with regards to formulary and provincial sort of vision for this. As you know, more and more drugs get put on the formulary, potentially from each of those categories, the GLP-1 and the SGLT2s. Is there an appetite for sort of streamlining, negotiating, getting the best price possible, getting, you know, 1 on formulary or 2 on formulary? Is that crazy to think about? Just your thoughts on that.
Well, no, we got Ozempic added to the hospital formulary. So that's available now. That's the only one that we have on our hospital formulary.
Yeah.
The SGLT2s, we have all of them except for canagliflozin we don't have on formulary, but the other two, so Jardiance or
The reason
dapagliflozin. Yeah.
The reason for my question is more to, because of the number, it becomes then a little, I find intimidating from clinicians' point of view because they become not familiar or they get their preference or how do we standardize a little bit, I guess is what I'm trying to get at. Should we be thinking about these things mostly in class effect rather than specific effect? And if we think in class effect, then we should really try to streamline what we do.
Yeah, and we kind of, at least when I'm initiating these treatments, I definitely start them more as a class effect.
Yeah.
That way, so as long as they're on one of, say, the SGLT2s, that I'm happy with it.
Yeah.
I might pick, say, empagliflozin if it's just a type 2 diabetic with just coronary vascular disease, other risk factors, because it does have more evidence for MACE than, say, dapagliflozin. So that might be the only reason. Most of the time now we're going with dapagliflozin just because it's generic, it's easier. We don't have to worry about the cost to the patient that way.
Yeah. Okay. All right. Thank you.
Thank you. Thank you, Krystyna. Thank you, Jeff. Any other questions? So I have a quick question for Krystyna. So we're dealing mostly with patients in acute settings. So what do you think will be realistic and what percentage of patients to achieve, guideline dictated approach by the time of discharge?
I mean, ideally, I'd like to get all of them on it, but most of the time, if they're coming in new diagnosis, we'll try and get at least an SGLT2 on them, or at least a prescription before they leave the hospital. Because a follow-up, as we know, is sometimes difficult with patients not having access to primary care providers. But we'll try and maximize what they're currently on, or at least change their current regimen to guideline directed. So I might switch somebody off gliclazide to dapagliflozin while they're in hospital, just to at least get them on evidence therapy for that. So it's something we're trying to do. We don't have a streamlined approach to that. So it's definitely an area we could improve for sure going forward.
Excellent. Thank you. Any other questions? Okay. Again, thank you everyone for joining us. Krystyna, thank you for a great talk. And I'll wish you a good day.
Thank you.
Thank you. Bye.